So we're talking about circulation and the physiology there. That's right. How does the blood get around? Okay, and what really controls it? So again, this is you should be. You just looked at the heart. This is not a whole lot different. Milliliters per minute. It's equivalent to the cardiac output for the entire vascular system, and it's relatively constant. It just varies with need. So, all you're still getting the cardiac output. It's a matter of distribution. All that is how we utilize our energy, how we plan out our day. We're going to spend an hour doing this, half an hour doing this, etc. Your body's no different in that. And so I don't do the physics of it. It's expressed in millimeters of mercury. That's what your blood pressure, those numbers. 120 over 80 is the given sort of number we base off of for the typical young to, let's say, middle-aged healthy individual. And and it has to be in the larger arteries near the heart. You can get blood pressure even lower than that. I mean, you can go down to the lower extremity. How often? I mean, I have one in my office. We have one of those wrist pressure things that they use all the time. Not so good, by the way. You're getting a little far away, but they're convenient. So a lot of doctors' offices will go, okay, put this on. The art of listening and assessing blood pressure has gone away because, as you will find out, if you're for those going into nursing or those going into other fields, basically these are basically just trained technical people who are doing these. They're going to they're going to do the basic measurements. They use whatever devices are there. There's no real science, and a lot of times it annoys the heck out of me because they get it wrong. Okay, and even when they try to do the old-fashioned, let's pump up the arm and listen to stethoscope. I'm getting 190 over 140. I'm like, oh, I'm still living. And then I asked, I remember one time asking my doctor to do it. He goes, let me see, it's about 130 over 82. Yeah, that's about what it feels like. So understand, and the devices themselves are not as accurate. They're useful for people who wouldn't know about what to do with them. They always tell you to be at rest and hold your hand like that. Fine. Okay. So pressure gradient, you're going to hear it again and again. It's just there are certain driving forces in your body. So concentration gradient is one of them. Hydrostatic pressure being opposed by colloid osmotic pressure. The force of hydrostatic pressure pushing against your blood vessels is offset to a certain extent because once it gets to the capillaries, all of it will just flow out. If you remember that from the blood, if it wasn't for albumin, those proteins in the plasma hold on to water. They're a colloid. And what that colloidal aspect does is it holds it in. Okay? So pressure is an important. It drives the bus just like concentration gradient does when we're talking about some of this thing. And resistance is the opposition rather to flow, and it has different things that are part of it. So one, it has to do with the thickness of the blood. If you recall, when we looked at the blood unit, we looked at things like polycythemia. People had a very, very high red count. Okay, higher when they're at elevation, people who blood dope, maybe people with some type of metabolic or cancerous condition. That increases viscosity, the thickness. So it goes from being fluid to being almost, when you talk about viscosity, you're almost getting like an oily or thickened oily consistency. It's that, when you use 530 versus 1040 oil in your vehicle, those are differences in thickness and viscosity. If you did, I didn't know that. So somebody explained it to me. Okay, and how long the total blood length. So you might read that and say, well, gee, the aorta is pretty short, but the femoral artery is pretty long. You're going to see it. They kind of add up the length of all the vessels, and most importantly, as the aggregate, as the diameter. I think as much as anything, because that's where we really control things. So the thickness or stickiness of blood, okay, all those things that are in it, the greater the viscosity, the less easily they can slide around, so it increases resistance. The longer the vessel, the greater the resistance, but the way they calculate it is really where diameter is a little bit more of an important factor. This is the big player, okay? So that's not going to change for the most part. Your viscosity, maybe if you're a little dehydrated or overhydrated, there'll be a subtle change in what's viewed as your viscosity. But the reality is that the resistance changes. So, and again, fluids move more slowly along the margins. That's going to play a role when we get, you want to remember that when we get to immune system. Cells and the fluids themselves and the cells they contain around the margins are moving more slowly. That's why it's easier, usually we'll see, for white blood cells to get out in the process of what we'll find when we talk about the immune system is inflammation. So centrally, it flows, they call it layered or laminar flow. And so if the radius increases, the resistance decreases. It just makes sense. If the vessel's like this, there's a lot of resistance. If the vessel's like this, there's very little resistance. Very straightforward. Now, but what's interesting that if the radius is doubled, the resistance drops to 1/16 as much. So it's a very significant. When I make it wider like that, I have really dropped the resistance just when you do the math that's associated. It's one of those like n to 2n to the fourth factor that's involved. So the big players, what all this means, and this is the part you have to know, the tiny arterioles that you can barely see are the major determinants of peripheral resistance. Okay, so it changes all the time. The big arteries really do not. Remember, I showed you in that initial diagram last time. It's because those big arteries, can they be a little taller or a little wider? But the reality is you can't compress them that much to make a significant difference. Or you can't decompress them or release them so much to make a significant difference. You can when you get to the arteriole level. Okay? These are different. And the whole idea, I talked about it a little bit when we talked about, pardon me, about the blood and clotting, and with this idea of laminar flow is turbulence. Anything in the way, whether it's fatty plaques, whether it's irregularities in the blood vessels themselves, multiple areas where it's overly tense, pick something and you get turbulence. Okay, and so again, if you think of you're going down the Yakagani and you go whitewater rafting, it's all because there's so many variations in the floor of that river in that particular area. It's here, shallow, it goes deep, deep, shallow, varying all the time, and that creates turbulence. Effectively, the same. Your vascular system is designed not to have that. Turbulence is bad because they slap together and clots form. Obstructions are bad. They slam together, clots form. Irregular heart valves, same deal. You're getting the idea. We want to not have that stuff. Okay, and again, it's unfortunately people don't realize it until all of a sudden there's what we call an event, something bad, and then it's very, very troubling. Okay, milkshake wouldn't be a bad idea right now. Food moment. Fish for us tonight. Hardly. Neither my wife and I have any religious inclination, but I love fish fries. What? Yeah, I didn't really have any. A couple crackers. That's it. No, I try not to eat a great deal at school. I'm going to heat something up in the refrigerator unless I bring something in from home that we had fun with. Just say. You making aspersions as to my weight? I'm not having my girlish figure. No, I'm just acknowledging that you talk more about food in this section than the other. What other section? Like when we had AP in the morning last semester and in micro, we don't talk about food as much as you do. Oh, in the afternoon. Yes. So maybe so. I thought about equal presenting about food. I'm being inconsistent. I digress. Okay. Pumping, pressure, opposes the resistant, highest in the aorta, declines, pathways, deepest drop, arterioles. This is the idea of why they basically control your blood pressure. Not so much the number of your blood pressure, but the distribution. So blood flow is here. Look at the way it drops off. At 120 over 80, aorta, arteries, the major named arteries, because you can't squeeze them. When we start to get to arterioles, look at the substantial amount of pressure drop off. The mean pressure, which means the average, that map that you will see in a second, the mean arterial pressure drops off significantly. And by the time we reach the capillary bed, look at the substantial decline in pressure, more effectively more than half. To understand that's when you hear about someone with high blood pressure, we're worrying about it less here and more here. It manifests itself as the bottom number, interestingly enough. That's a really rapid indicator, but that's not necessarily where the problem is, if you want to think of it that way. So how elastic, we call that compliance or distensibility. Think of it this way. If you, I'm sure at some juncture you had a party and you blew up balloons yourselves by mouth. What'd you do first for the balloon before you blew it up? You stretched it, right? Exactly. That's you're increasing its distensibility or its compliance. Your blood vessels are no different. Down the road, when you look at what happens in aging, you look at that in a variety of courses. We don't generally get to it in this course, unless they have it included in one of the PowerPoints. It's basically that that elasticity begins to lose. That's why people, as you get older, there's a little higher tolerance for that lower number to go up. So at my age now, 85 to 90 is probably acceptable. Okay. And I mean, if somebody who, really a senior citizen by art, but remember, 70 is the new 50. I'll keep saying that. So I'm 80. Then 80 will be the new 50. Okay. But you understand what I'm saying? Then it used to be when you got to 70, 75, like my age now, you could even accept 90. My family doctor would not be a happy camper. That was my number. No. Okay. And then how much blood is in them? So pulsatile means that you have, if you look backwards, we have this kind of a way of assessing. You can't assess it in your arterioles. In order for it to detect the pulse, you actually have to have an area where there's enough of a gap to be able to detect the pulse. That's there. So in the aorta, that's by definition, think of that not so much as the maximum, but the maximum under normal, what it reaches as a maximum under normal circumstances. Stances. It's got to be enough to stretch that aorta to get that rebound phenomena. Average 120, plus or minus whatever. It's my wife is only a few years younger than I am, 6.5 approximately. I mean, her typical pressure is 110 over 60. It's not unusual to have lower numbers in women, women particularly who are slender. It's not unusual whatsoever. Having lower than normal blood pressure is not pathological. It's not a disease entity. Okay? If anything, it's associated with more or the greater degree of longevity, as long as that blood pressure is sufficient to provide blood flow to where it has to go to the necessary organs. Okay, that's all. So it's not, understand, even that number, if that average number was around 70 or 75 and that was their normal, that's fine. It doesn't have to be high. It doesn't have to be 120 over 80. So, and the lowest level aortic pressure is when the heart is at rest. Typically, that's the diastolic. That's the that is the measure of resting tension in those arteries, those measurable arteries that are there. That's such an important measure. We said it before. That's how much the heart has to deal with. The difference is called the pulse pressure, and we can detect that, okay, because there's a significant difference in pulse pressure that we can feel under the skin in limited areas. That's all there is to it. We classify that as what's called the MAP, mean arterial pressure. It's a very easy calculation. You're going to see it. They'll do it for 120 over 80. The idea is that you're probably at the 120 1/3 of the time, and they more at the 80 about 2/3 of the time, more or less. So what they do is they take the pulse pressure, the difference between 120 over 80, that's 40, divide by 3, that's roughly 13 or 13.3 repeating. And so if you add that 13.3 to the diastolic, the map at that typical 120 over 80 would be 93.3. Okay, you're going to find out that your body is very content. Your kidneys can work just fine, and they're really the ones who are affected most by blood pressure abnormalities. As long as that average MAP or MAP is not around 90, but between 80 all the way up, maybe up to 180. And obviously, the longer it's at a real high number of like that, it's going to cause some damage, significant damage. But I mean, if you're having that number between 80 and 100, even somebody with treatable high blood pressure, or even poorly or somewhat undertreated high blood pressure, they're going to do fine, at least for a while. The longer you have something that isn't taken care of, the greater the amount of damage. That's why there's nothing else about high blood pressure, nothing else about this unit. That's why we call it the silent killer. Because there's no alarm clock going off. Okay? You're not seeing the skin change to a particular color. You're not seeing notable growths someplace. There isn't a magical blood test that's going to point that out. All of a sudden, something bad happens. And sometimes that something bad can be fatal. So the heart spends more time at rest than it does pumping, and that's the point I was trying to make. And here's the calculation. So the pulse pressure and MAP both decline with increasing distance from the heart. So you're measuring it relatively close. So pick an area. Typically, the classic areas, typically here along the brachial artery. Did you do where the arteries were located in lab? You had lab last 2 days. So what did you do in lab?
It's more about labeling the arteries and how blood flows.
Yeah, okay. So which did you find out where the brachial artery is?
Yes.
Yeah. So you put it over by the brachial artery. The brachial artery is okay in the flexor area. It's probably along the border of the biceps brachii, more medial than lateral. Nothing drives me. It's my ultimate pet peeve. Somebody who doesn't know what they're doing with blood pressure. You know, there's a little sensor on that thing. You ever see the blood pressure cuffs? They have a little place where you're supposed to put it where the artery is. They end up putting it back here, over here. What in heaven's name are they doing? It drives me crazy. Or they put it so that when it increases, you hyperextend your elbow. It's like I once tore it off and I tossed it to my wife or something. Because whoever this tech was at a hospital was like, do you have any idea how to take your blood pressure? I take them all the time. Do you ever get one right? I'm the patient you don't want to have. Know now, doctors make the worst patients. They do. They're awful. They have a zero-inch policy for stupidity. So understand, you got to put the sensor here. You got to put the stethoscope here, or you can't hear it. Or even if you're doing it automatically, have a device. Aren't they in the right place? Drives me nuts. So vital signs: pulse and blood pressure, along with respiratory. You all know that. So the radial pulse is easy to use. Okay, because it's easy to get. You don't have to get somebody to take their shirt off or to move it here or pull it up like that. Super easy to get to. The key, light touch. Okay, a lot of people as they're older, I mean, you could squeeze that darn thing shut. So gently from the thumb, feel the tendons over here, gently over there. Always 2 fingers. Sometimes you can even see it pulsating. That immediately tells you there's high blood pressure. Okay, and you can feel it. And that's how when we used to do radial sticks to do arterial blood gases, we didn't have that pulse ox thing. That was in its infancy, and we used to have to, in order to find out what somebody's oxygen was in their system, what you measure with that little finger device, pulse ox, we had to take arterial blood out. It was called an arterial stick. You did it right there. So gentle pressure on it and just count. Okay. So where arteries are close to the body surface can be compressed to stop blood flow in the event of hemorrhaging. That's something else to remember. So vis-a-vis tourniquets, tourniquets are a little harder to deal with. The places. Sometimes you can actually see it here, particularly with high blood pressure, and people will feel it. If they come to you and say, "Oh man, I feel like it's pulsating here," watch out. High blood pressure. You know when I've seen people have that? Well, there's not. It's a couple of oddball inflammatory conditions. That artery, did you learn about this one? It's called the superficial temporal artery. The end, you heard about the external carotid. Is that ringing a bell? The termination of the external carotid is the superficial temporal artery. That's where termination means it's no longer the external carotid, it's the superficial temporal. I mean, that's classic anatomy in that sense. So there's a thing called superficial temporal arteritis. So autoimmune diseases sometimes present with that if you're interested in that. And then so a lot of people will feel that. They'll feel that, and you can even see it sometimes, that pounding that's going on there, particularly with high blood pressure. But you don't often use it. The facial artery, sort of behind your jaw, very difficult to get. But if you take the angle of the jaw, and this is, and if you did learn CPR, this is what they taught you, right? That's you're getting the carotid pulse. It's a very useful pulse. So that's relatively easy to find. That's roughly the common carotid. Actually, if you the angle of the jaw is pretty much the bifurcation, and he went over how it's common carotid, then it's split into internal and external carotid. Where it bifurcates, we're coming to that. That's an important anatomical place. Okay, because of a couple of sensors that are in there that are really super important. That's kind of one of the areas where you look for the pulse. Others, we know the brachial, again, it's in the flexor area. It's more medial than lateral. It's probably along here would be a better. Radial is very self-explanatory. Hard one for me to get behind your knee is the popliteal. It's difficult because there's a lot of heavy muscular tissue. The next easiest one to the radial is right behind your ankle. It's right behind you. Remember your anatomy, the medial malleolus? You reach right back there. Very easy pulse to get. One that's fairly hard because it's very easy for you to push too hard on it and miss it. It's called the dorsalis pedis. This is the posterior tibial. The anterior tibial artery comes down here, following that line, and then where it terminates, it becomes top of the foot, dorsalis pedis. That's a hard pulse to palpate. So, I mean, depending on if you can be somebody can work out something up above, and they say, "Oh, get me a pulse." Well, you might be in the way if they're trying to put leads on for an electrocardiogram. Just go pop right down there and feel behind the ankle. You can get a pulse there easily enough. Now it brings us to the femoral pulse. It's not something you're going to routinely check because in a man or a woman, immediately you're in a sensitive area in the groin. It is extraordinarily important. Okay, that is where we catheterize people when we have to do cardiac catheterization. It's a very significant area. So sometimes that's an important access point. It takes some doing to know what you're doing. The pulse is not hard to find. Okay, the act of catheterization is something a physician would do. I've seen many of them done. I've seen them done in radiology. Because what they'll do is they'll pass up a catheter and shoot dye in it and take serial X-rays. That's one of the ways we used to image the heart. I'm sure they still do the cardiac angiography. I mean, thankfully, we have some very sophisticated scanning techniques now that will take the place to some extent. So, and again, how we're going to be able to do this is systemic arterial blood pressure, auscultation, stethoscope, the device, sphygmomanometer. Okay, the sounds that you're hearing are called carot cough sounds. And I mean, basically, the top number is when you hear the first sound, and when you hear the last sound, it's the bottom number. Make it easy. I'm not going to ask you about the name carot cough or how to take a blood pressure. That's lab. Whether you do it in lab or not, but that's what to me that's lab. When I say it, make no mistake, I'm not being critical or not being critical of what you're doing in lab. That's for me. That's something for me that you cover in lab. That's all that means. And here they are just telling you that. And interestingly, at a capillary bed, it's a bit different. Okay, ranging from 35, so it gets down to a capillary bed. Wait till you get to the kidney. That number for the capillary beds in the kidney is way up. It's at 55. And we'll get to why there's a reason. It's anatomical. And as anything are that are uniquely anatomical, there's a physiological thing that it accomplishes. So it ranges from 35 at the bed till 17 at the end. All of those numbers are relevant because it ensures why oxygen and carbon dioxide exchange. It also ensures why nutrients exit and waste products come back in. Okay, so it's desirable because high blood pressure would rupture fragile capillaries. The ones in, you see, the ones in the kidney are not so fragile, not so much the capillaries, the arterioles, and most capillaries are very permeable. So low pressure forces filtrate into the spaces. You don't need a lot of pressure to get the stuff out of there into those spaces so it can do its thing, exchanging, waste products, etc. Then it'll follow concentration gradients. So let's just see. So the venous blood pressure is a bit different. It doesn't change a whole lot. Okay. It typically stays around at the end of that capillary. It's about 15 millimeters of mercury. Okay. And so, and that's the difference. You'll all be acquainted typically when you see somebody bleeding, it is venous blood. It's very easy to detect arterial blood, and it's somewhat frightening because they will have what's called a pumper. Every time their heart beats, you're going to see squirts. And the color of the blood is distinctly different. Okay? Venous blood is a dark red, not quite a red, it's not quite what you see in the color of your veins, per se, because once the blood is exposed, it immediately changes color. But it's a duskier red. Arterial blood is closer to a cherry red. It's a much redder kind of a red, if that makes any sense. And when you see a pumper, and generally when somebody cuts themselves and they see that pumping, they get really excited. So their heart rate really increases. And whose wouldn't? Okay. So the blood spurts out because the pressure is higher. Low pressure is due to cumulative effects of pressure resistance. Okay. All these kinds of things are there. Low pressure on the venous side requires adaptations to help venous return. Yeah, let me flip. I'm going to flip it back because I swear I forgot something at the beginning when I started this unit. Just hold on. Nope, didn't. I must have been looking at a different set of slides. We're getting there. Sorry. This is hard to do. Pumps. I love this. Venous return. Effectively, I don't know how there's an easy way to describe it or not. I don't know anything is that easy to talk about it. But effectively, it's almost kind of what your heart acts kind of like a cycle. So if you have blood going in to the heart this way, I'm very, very simplistic diagram. Roadway in, roadway out. Blood's in here, in the middle of this muscular hollow area without going crazy. When it's pressed, the blood exits. Okay, so if you know how a siphon works, or if you ever had to siphon gas out of something and into something, when you squeeze it, okay, it pushes the fluid out. When you relax it, it sucks it back up. That's a siphoning action. We have a lot of this. So effectively, it pushes, it squeezes this way, but as you release the pressure and allow that rubbery thing or elastic thing to expand, it creates a suction force to pull things back in. That's a siphon effect. And then, in the old days when you ran out of gas, sometimes you had to siphon some gas out of one car, and once you got it flowing, and gravity take over and put it to another. So basically, they're a function of gravity. Siphon, a strange word. Uh, or, oh, I said it's all right. I'm showing my age. My boss, Dr. Badger, and I were commenting on the movie Galaxy Quest. Most of the students aren't familiar with it. Anybody in a scientific field should be, I mean, there's certain movies you have to see. Any Mel Brooks movie would be part of it. Galaxy Quest would be part of it. Just have to. There's so many good lines. I may make this a homework assignment. You don't like movies? It's, what? Oh, you wouldn't fall asleep to this? Do you like Harry Potter movies? The guy who played Professor Snape, Alan Rickman, he's in that. The late Alan Rickman, wonderful actor. He he plays a character like Mr. Spock on Star Trek. No Star Trek fans? Would it surprise any of you that we used to go to? Didn't I tell you we went to Star Trek conventions? I had Vulcan ears.
They show that involves space.
What?
Any movie that involves space is sad.
Never get.
Nope. I've never even seen Star Wars. I saw it.
Oh, you're in trouble.
I have not.
There's abnormality here. I'm surrounded by strange people. God bless. When that movie came out, when those movies came, we have to have a discussion. I want to know your diet. It could be a dietary thing.
Dr. Science, do you like the Big Bang Theory?
No, every student asked me that, and I did not find that show engaging at all. It was too cute by half. You know, they're making a conscientious effort to. They were not as in touch with their inner nerd as they thought. Hey, look, I have a nerds are us type of thing. If you, hey, look, pocket protector, bow tie, suspenders. Yes. Clip your gloves, those little snappy things in the winter so you can lose them. That's, don't judge me. When Star Wars came out, the lines around the theater. Understand, we didn't have streaming and TV. I mean, you're waiting. You're happy to get a ticket to get in. You'd sit anywhere on the floor. And we stood up and applauded. In the movie Rocky, we stood up and applauded at the end of that. Rocky movies, is it ringing a bell? Sylvester Stallone, up the steps at the. Lord help me. Stranger in a Strange Land. We have to talk. We're going to have movie night together. We're going to put them here. I'll get the screen. I have them all on my computer. I have all the apps. So this is the idea of a muscular pump. Your muscles are doing the same thing. Your muscles surround the blood vessels, the veins, and they push on them. And remember, the veins have valves, and basically the blood goes up. It's compartmental. Okay, if they almost go because the valves, it basically keeps going in the right direction back to the heart from the extremities opposing gravity. Okay, the valves prevent backflow. Respiratory, by changing, you're squeezing the abdominal veins, the diaphragm is expanding your chest. That's a pump. Okay, and even there's a certain amount of constriction of those veins by the sympathetic nervous system. Everything going back to the heart. This is a very good example. We call it the column of blood. So blood is here. This is a section. Imagine section. And so let's say these are your calf muscles, which are a very, very strong pump, by the way. They squeeze here, push it up. When the muscles relax, the valves shut. And so it doesn't permit backflow. So it moves the column up at least a segment or several segments at a time. That's the idea. All these wonderful adaptations to make sure there's adequate venous return. Okay, so blood pressure requires cooperation of all of these structures. It's all interrelated. The heart, the vessels, and you've already heard me today mention a couple of times kidneys. Because kidneys, one of the things that kidneys do is they control the amount of fluid in the system. The more fluid, the higher the pressure. The less fluid, the lower the pressure. For years, the way we dealt with high blood pressure was we tried to basically found medicines that made people urinate more. We didn't have a whole lot of other things that worked, and it was very inconvenient. And the medicines had a fair amount of side effects. We learned over time because it was we were losing potassium and things like that. But the reality was it was good strategy. We do it all the time in the hospital. You're going to hear about a medicine that works to get rid of the fluid that we use in the hospital because we can control it, called Lasix. Lasix is the trade name. You will know it as furosemide. It's typically there are pills for it, but typically it's used in the hospital because it can get the fluid out in a hurry. So here are the big factors: cardiac output, the resistance, and how much fluid's in the system, volume of blood. And the blood pressure varies with all of these. Not doing this. Not doing it. Okay. Not doing it. Now we're doing it. So we have controls, nervous system controls, hormonal controls, and kidney controls. So there's a lot of factors that are involved. I'm sure we won't complete all of this. But this idea of the mean arterial pressure is so important. So if we increase, you remember cardiac output is a function of heart rate and stroke volume. You increase one, you're going to increase the output. Increase another one, etc. Things that, again, we're looking at thickness of the blood, length, decreasing diameter of the blood vessels, they increase resistance. And that combination leads to that mean arterial pressure. Think of this as more systolic and this is more diastolic. Okay? So the neural control mechanisms altering blood vessel diameter. Okay? If the blood volume drops, the whole idea, if when somebody is injured, someone's in an accident, whether it's internal or external bleeding, the body goes into emergency mode. The two areas which have to have blood supply immediately that are protected, you see them right there, the heart and the brain. Doesn't matter where you are, what you're doing, the brain basically gets the same amount of blood. And so if the blood volume drops, you had an injury, there was internal bleeding, you had external bleeding, all the other vessels will constrict, the brains will remain open, and the heart will remain open. Because if those go, the person's not going to survive. It doesn't matter what's causing it. Okay? And so in response to those demands, sometimes we will alter it. That's circumstances. So in fight or flight, we talked about that. You're going to shunt the blood differently. You're going to direct the blood to the heart and to skeletal muscle, maybe a little bit to the skin for cooling purposes. That's about it. Brain's going to get its share. We're going to take it away from the gastrointestinal and genitourinary system. So there's reflexes that are involved. This is important. Okay, I told you about it before. So we have a center that controls your heart rate in the medulla oblongata. That's the brainstem. If you remember from A&P what I told you, the place that you're worried about when there's damage is the brainstem. Is there a tumor? Was there trauma? Because all the controls that we don't control, all the autonomic controls are there. So they're in the medulla and in the pons. When it's damaged in those areas, generally schools out. We have pressure receptors and chemical receptors, and we even have higher brain centers that overlap. Okay, so they are. Baro means pressure, chemo is self-explanatory. Baroreceptors, you will come to know, are stretch receptors. Remember I was telling you here, when you do like in CPR, you're looking for the carotid artery. At that bifurcation, where the carotid artery bifurcates, the common carotid bifurcates into the internal and external, there are both pressure receptors and chemical receptors that come into play. Reason one why they come into play is to make sure you have enough blood flow going to the brain. There's another set of those receptors, both baro and chemo, in the aortic arch. You learned about how the blood came out by way of the aorta. You had the arch, you had the vessels that came off it. Remember brachiocephalic trunk, right? See, I took this course. Left common carotid. Yeah, in my sleep on my worst day, I could tell you all those blood vessels. That's right. I'm here to help. Okay. There, in that aortic arch, there is a pressure receptor and a chemical receptor to make sure we're going to have adequate circulation or perfusion. In other words, enough circulation and oxygen for those organs to survive, etc. So clusters of sympathetic nerves. This is in the cardiovascular center. Okay, there's a cardiac center that will either accelerate it or inhibit it, and then there's another center. This is all sympathetic, and the only fibers that go to blood vessels are sympathetic. Only. If they're super active in fight or flight, it's going to squeeze a lot of blood vessels. If they're not active, they have a residual tone that I keep talking about. The sympathetic tone, the resting pressure in those measurable arteries, the bottom number on your blood pressure. Okay, that's the vasomotor tone. That is your diastolic. And so it gets inputs from all of these to make those determinations. We will, in the interest of not too much, we're going to look at the baroreceptors. We're going to look at the chemoreceptors and all of those things. And you'll see a location where these are. I should have it for you. I don't see it here, but we'll find it. Okay. I'll try to find an illustration of it. Thank you very much. Have a very good weekend. Bye. See you.